Already we had discussed in the last class a major part of the stomach cancer. I had discussed the etiology, pathogenesis, its incidence, its classification, and a small part of microscopic appearance and the gross appearance. এইগুলো বলেছিলাম, clear? Okay. Now few parts are remaining. So for that reason I am taking this today's class, but today's class is very much related with the previous class. So if you don't know what was taught in the previous class, you will not understand this part. Okay. You stand up? Yes. Stomach cancer পড়েছো? Okay. Very good. মানে আগে ক্লাসে তুমি ছিলে না যে তুমি স্টমাক ক্যান্সারটা চ্যাপ্টারটা পড়েছো, ফাইন। কি পড়েছো সেটা বলো।
Types of
মাইকে বলো, মাইকে।
types of stomach cancer.
Types of stomach cancer. Tell me types of stomach cancer.
So there are 7 types.
7 types, okay. Tell me the classification of stomach cancer.
একটা লরেন্স ক্লাসিফিকেশন হয়,
Lawrence classification, very good.
আর ব্রমেন্স ক্লাসিফিকেশন,
Yes, Borman's classification, okay.
এক WHO ক্লাসিফিকেশন।
Does WHO classification. Tell me, তুমি পাশে জনকে দাও। You tell me about WHO classification of stomach cancer.
Sir, adenocarcinoma.
Very good.
Squamous cell carcinoma.
Squamous cell carcinoma, very good.
Adenosquamous
Carcinoma, very good.
carcinoma.
Then
Gastroblastoma.
very good.
Neuroendocrine tumor.
Yes, very good.
Neuroendocrine carcinoma.
Carcinoma, very good. Yes. বাস এইটুকু বললেই হবে। ওকে, পাশে জনকে দাও। Now you summarize all the 3 classification of stomach cancer.
First is Borman's
Very
classification. Type 1 is polypoid, type 2 fungating, type 3 infiltrative,
Ulcerative.
type 4 infiltrative. Lawrence classification, intestinal, diffused and mixed, and WHO classification, adenocarcinoma, squamous cell carcinoma, adenosquamous carcinoma, gastroblastoma, neuroendocrine tumor, neuroendocrine carcinoma.
Okay, very good. So you tell me about WNT pathway. তাহলে আমি WNT pathwayটা ছোট্ট করে বলে দিচ্ছি। In the WNT pathway there is a WNT receptor. Fine. WNT receptor is there. In the cytoplasm there is a protein called Beta-catenin. ঠিক আছে? কি প্রোটিনের নাম? Beta-catenin. That naturally it is present in the cytoplasm in association with APC protein and forms a complex with it. Clear? Normally beta-catenin is present in the cytoplasm not in free form, in association with APC protein. Clear to all? Clear? And what does it do? APC after binding with beta-catenin causes degradation of beta-catenin. Clear? Clear হয়েছে? Okay. The rest of the 50% of the beta-catenin is associated with E-cadherin. Clear? What is E-cadherin? Yes? কি আছে? তুমি বলো। Adhesion. Yes, very good. It causes cell to cell adhesion. So E-cadherin protein at the outer surface of the cell, it is causing cell to cell adhesion. At the inner surface means intracellular part of that protein is doing what function? What does it do that there? Extracellularly it is causing association with other cell. Fine. Intracellularly it is binding with beta-catenin and causing it means it is inhibiting the free form of beta-catenin. Clear? So normally beta-catenin is absent or in very low amount in the cytoplasm. Clear? In normal state. Now, when the WNT molecule comes and binds with its receptor, WNT receptor, the signal transduction pathway starts and it results in dissociation of APC from which? Beta-catenin. Yes. So that will result in increased intracellular level of beta-catenin. This beta-catenin will go to nucleus. Clear? And bind with TCF and start transcription of genes which are related with cell division. Clear? Clear to all? Clear to all? Okay. মাইকটা কার কাছে? তোমার কাছে। পাশে জনকে দাও। You tell me the WNT pathway. বলো। এখানেই আছে।
Beta-catenin bind to
মাইকে
the
বলো হ্যাঁ।
Beta-catenin bind to the APC and destruction.
First tell me about the resting state. Resting state কি থাকছে? After exposure to the WNT molecules কি স্ট্যাটাসটা হয়ে যাচ্ছে? দেখে বলো। This is resting cell. This is WNT stimulation. বলো এখানে কি হচ্ছে? দেখে বলো। পারবে না? পাশে এনে দাও। বলো এটাতে কি হচ্ছে? এটা কি আছে?
E-cadherin.
এই যারা যারা বুঝতে পারেনি তারা ভালো করে দেখো। এটা কি আছে?
E-cadherin.
E-cadherin কাজটা কি?
adhesion করা
কার সাথে?
B-catenin এর সঙ্গে।
কার সাথে?
B-catenin এর সঙ্গে।
Beta-catenin.
Beta-catenin.
Okay, that is the intracellular function. Extracellular function কি করছে? Adhesion with other
Cell to
সেলের
cell.
E-cadherin সাথে bind করছে। এটাও তো E-cadherin of another cell. It is actually binding with the E-cadherin of other cell causing cell to cell adhesion. Clear? And intracellularly it is binding with
Beta-catenin.
beta-catenin. Okay, so it is binding with 50% of the beta-catenin. Fine. Rest of the 50% of the beta-catenin is bound with
APC.
APC. Okay, so this APC is causing
Destruction.
degradation of the beta-catenin. Clear? This is the resting stage when there is no WNT molecules. Now WNT molecule comes, what will happen? বলো এবার এটা কিছু এফেক্ট হচ্ছে? হচ্ছে না।
না।
এখানে কিছু হচ্ছে? এপিসি তে কিছু হচ্ছে? এখানে তো এই যে এটা কি একই?
Bind
এপিসিটা আলাদা হয়ে যাচ্ছে তো। কেন বলছো যে কিছু হচ্ছে না?
রিসেপ্টরের সঙ্গে বাইন্ড করবে।
রিসেপ্টরের সঙ্গে বাইন্ড করলে যে সিগন্যালস গুলো যাচ্ছে ইন্ট্রাসেলুলার সিগন্যালস সেগুলো কি করছে? এপিসিটাকে বিটা ক্যাটেনিন থেকে আলাদা করে দিচ্ছে। তারপর কি হবে? তারপর কি হবে?
Beta-catenin intercellular.
Beta-catenin will not be degraded resulting in increase করবে না ডিক্রিজ করবে কনসেন্ট্রেশন?
increase করবে।
increase করবে। Then it will go inside the nucleus, bind with TCF and will cause cell proliferation. Clear হয়েছে? Clear to all? পাশে জনকে দাও। এবার তুমি ভালো করে বলো। দুবার বুঝিয়েছি।
স্টার্টিং এ নরমালি আমাদের বিটা ক্যাটেনিন 50% এপিসি এর সাথে বাইন্ড থাকে আর 50% ই ক্যাটেনিন এর সাথে বাইন্ড থাকে। ই ক্যাটেনিনের কাজ হচ্ছে দুটো সেলকে মানে একে অপরের সাথে জুড়ে রাখে।
ওকে,
তারপরে যখন WNT মলিকিউল এসে WNT রিসেপ্টরের সাথে বাইন্ড করে তখন এপিসি বিটা ক্যাটেনিনের থেকে ডিসোসিয়েট করে যায়।
ওকে, ভেরি গুড।
তো তো এপিসি মানে আর বিটা ক্যাটেনিনের ডিস্ট্রাকশনটা আটকে যায়, তো বিটা
ঠিক আছে।
ক্যাটেনিনের ইন্ট্রাসেলুলার লেভেলটা বেড়ে যায়, তো
Okay.
তারপরে বিটা ক্যাটেনিন গিয়ে আমাদের
its
নিউক্লিয়াস
concentration will raise
কনসেন্ট্রেশন বেড়ে যায়, তো
and
নিউক্লিয়াস
it will go into the nucleus,
nucleus
bind
is-
with TCF, causes cell proliferation.
Yes, sir.
Clear? ঠিক আছে, পিছনে জনকে দাও। ঠিক আছে, বসো বসো বসো। ঠিক আছে, তাহলে WNT পাথওয়েটা ক্লিয়ার হয়ে গেছে সবার? ক্লিয়ার টু অল? ওকে, আচ্ছা ইউ টেল মি, হ্যাঁ তুমি এবার করো, নেম অফ দ্য জিন which synthesize the E-cadherin protein. You know that or don't know?
E-cadherin gene.
E-cadherin যে প্রোটিন আছে তো, এটা কোন জিন তৈরি করে, নামটা কি আছে ওই জিনের?
Sir, CDH1.
Yes, very good. পাশে জনকে দাও, very good. Tell me the name of a gene which synthesizes beta-catenin protein. কি আছে, জানো কি জানো না?
CTN.
CTNN B1. Yes, very good. পাশে জনকে দাও। Tell me the name of a gene which synthesizes APC protein. আচ্ছা এর নামটা বলো, E-cadherin কে সিনথেসাইজ করে?
CDH1.
Yes,
CDH1.
CDH1. Okay. Beta-catenin is synthesized by, এখনই তো তোমার পাশে বন্ধু বলেছে, Beta-catenin is synthesized by,
CNNB.
yes,
CNNB.
CIN,
CNN.
CT,
NN.
কি বলছে?
CTN.
CTNN B1. Okay. Tell me the name of gene which synthesizes APC protein. Are you getting my question? পাশে জনকে দাও। You tell me, তুমি কি ফার্স্ট টাইম এসছো ক্লাসে? এর আগে দেখিনি। আজকে আমার ক্লাসটা ফার্স্ট টাইম অ্যাটেন্ড করছো?
First time.
ওকে ফাইন। তোমার কি সাপ্লি ছিল?
Supply.
Okay. You tell me the name of gene which synthesizes APC protein.
APC gene.
Yes, very good. That name of the gene is APC gene. পাশে জনকে দাও। বিটা ক্যাটেনিন পাথওয়েটা, WNT পাথওয়েটা ক্লিয়ার হয়ে গেছে? ক্লিয়ার হয়েছে? ওকে, বসো। Now, coming to our topic, already these things I had discussed in the last class. Now, going further, yes, তুমি দাঁড়াও। You tell me which is the most common location of gastric cancer?
Pyloric antrum.
Very good. Pyloric canal or pyloric antrum. Antrum is the most common region. পাশে জনকে দাও। Yes. Tell me what are the parts of stomach? কি কি parts আছে?
Fundus, body, pylorus.
Cardia?
Cardia.
Cardia. Okay. পাশে জনকে দাও। So, তুই আপাতত বসো, পরে আমি জিজ্ঞেস করব। So, these all the things were discussed. Clear? Adenocarcinoma কত রকম আছে? Tubular adenocarcinoma, parietal cell adenocarcinoma, papillary adenocarcinoma, micropapillary adenocarcinoma, signet ring cell adenocarcinoma, signet ring cell carcinoma, poorly conceived carcinoma, অনেক রকম আছে। ঠিক আছে, এই দু তিনটে মনে রাখলেই হলো। ঠিক আছে, মোস্ট কমন ওয়ান ইজ দ্য টিউবুলার অ্যাডিনোকার্সিনোমা। ঠিক আছে, এই রকম দেখতে হয়। ঠিক আছে, বুঝতে পারছো তো? এটা অ্যাকচুয়ালি গ্ল্যান্ড বা টিউবুলস লাইক, it is looking like tubules. So these are the malignant cells forming tubular structure. We call it tubular adenocarcinoma. Okay. Next, this is the malignant cells are not forming any glandular structure. Fine. So it is called as poorly cohesive carcinoma. Okay, clear? Mic কার কাছে আছে? দাঁড়াও। So poorly cohesive carcinoma এটা তো WHO ক্লাসিফিকেশনে আছে, আর টিউবুলার অ্যাডিনোকার্সিনোমা এটা WHO ক্লাসিফিকেশন আছে। কেউ যদি লরেন্স ক্লাসিফিকেশনটা ফলো করে, এটাকে কোন ক্যাটাগরিতে ফেলবে আর এটাকে কোন ক্যাটাগরিতে ফেলবে এটা বলো। এটা কোন ক্যাটাগরিতে যাবে আর এটা কোন ক্যাটাগরিতে যাবে?
এটা ডিফিউজড ক্যাটাগরি।
এটা কোনটাতে যাবে?
ডিফিউজড।
Intestinal. Yes, it will go into in the intestinal type. And this one?
ডিফিউজড।
Diffuse type. Very good. পাশে জনকে দাও। আপাতত বসো। This is signet ring cell carcinoma. It's a type of adenocarcinoma. ঠিক আছে, signet ring cell কেন বলা হয়? এটা কি দেখতে পাচ্ছ? কি লাগছে এইগুলো? Adipocytes. কেউ adipocyte বলছে নাকি? These are the malignant cells filled with mucin and looking like signet rings. Okay, that's why these are called as signet ring cell carcinoma. These are actually poorly cohesive. Fine? ঠিক আছে? Clear to all? Now, a major group of stomach cancer is poorly cohesive. Why those tumor cells are poorly cohesive? কেউ আন্দাজ করে বলতে পারবে? একটা গ্রুপ আছে intestinal type which is cohesive. Cohesive আছে, ওটাতে gland formation হচ্ছে, তার মানে cells are not dissociated with each other. But a major part is also diffuse type. মানে সেলগুলো একটা সেল এইদিকে একটা সেল ওইদিকে, মানে not in close contact, not forming any glandular structure, like in the diffuse type of Lorentz classification or poorly cohesive carcinoma of the WHO classification or signet ring cell carcinoma of the WHO classification. So why? It is something related with the WNT pathway. হ্যাঁ, তুমি বলো। মাইকটা এইদিকে পাস করো, এইদিকে পাস করো, বলো।
Destruction of E-cadherin.
Destruction of
E-cadherin.
E-cadherin. No, not destruction. It could be mutation. Mutation of the E-cadherin gene means CDH1 gene. Mutation in the CDH1 gene. What will be the result? There will be
Improper.
no cohesion between the cells and free beta-catenin inside the cell, leading to cellular proliferation. Is very good. She is absolutely correct. One major group of stomach cancer is discohesive because of this reason. Okay. Now, I will discuss this a bit later. First, I want to discuss some genetic syndromes related with gastric cancer or stomach cancer. First syndrome কি লেখা আছে? Hereditary diffuse gastric cancer syndrome. মাইকটা কার কাছে আছে? তুমি পাস করো। You tell me which gene is involved in this genetic syndrome.
CDH1.
CDH1, yes. So, in this condition, the person is having normally two CDH1 allele. One allele is mutated, contracted from one of his parents. Fine. And the other allele, which is functioning, it gets inactivated during his lifetime. Fine. So, when both of this gene gets deactivated, it will result in gastric cancer.
Gastric cancer.
Okay. পাশে জনকে দাও। Can you tell me the name of the hypothesis which explains this type of condition? Means one gene is affected, another gene is functioning, and ultimately during the lifetime both of the genes gets mutated, resulting in the carcinoma. Any hypothesis? Name of any hypothesis? Knutson's hypothesis? Knutson's hypothesis in the neoplasia chapter? You didn't heard that? Okay. You go today at your residence hostel and read the neoplasia chapter. Okay? So, if there is CDH1 mutation, what will be the result? মাইকে বলো।
Sir, the proto-oncogene will enter in the nucleus.
জোরে বলো, শুনতে পাচ্ছি না, জোরে বলো।
After the mutation, the APC and the E-cadherin will be separated, and the proto-oncogene.
E-cadherin is absent. Okay?
And the
If
proto-oncogene.
CDH1 is, by indirectly it is acting as tumor suppressor gene. Okay? So CDH1 is absent.
Yes, sir.
It will result in absence of E-cadherin. So there will be no cell adhesion. Next, how it is causing malignancy. It was also associated with beta-catenin intracellularly. Clear? It was associated with beta-catenin. Clear? So beta-catenin level will rise in the cell and result in cellular proliferation, causing hereditary, diffuse gastric cancer syndrome. Clear? Okay. Now this mutation, this mutation leads to which type of cancer?
Hereditary diffuse gastric cancer.
Diffuse gastric cancer. Any other cancer associated with this syndrome? Have you heard about any other cancer associated with CDH1 gene? Which is actually can occur in females. ব্রেস্ট ক্যান্সার পড়ানো হয়েছে? ব্রেস্ট ক্যান্সার পড়ানো হয়েছে? হয়নি? ওকে, ঠিক আছে। ব্রেস্ট ক্যান্সার অনেক রকম হয়। মোস্ট কমনলি ইট হ্যাজ বিন divided into two types. One is infiltrating ductal carcinoma, another one is invasive lobular carcinoma. The lobular carcinoma is actually associated with CDH1 gene mutation. So if a female patient is having this mutation, she is having risk of two cancers. One is
Hereditary diffuse
stomach
gastric
cancer, means poorly cohesive cancer of the stomach. Second one,
breast cancer.
lobular carcinoma of the breast. Okay, ঠিক আছে। Now the second syndrome, তুমি দাঁড়াও, সেকেন্ড সিন্ড্রোম নামটা পড়ো, কি আছে?
Gastric adenocarcinoma and
Proximal polyposis syndrome. Okay, this is associated with which gene?
APC gene.
APC gene. Very good. Tell me pathogenesis. Again the WNT pathway.
Sir, beta-catenin is associated with.
Maike bolo.
Beta-catenin is associated with APC.
Very good. In
So
the resting state.
resting state.
When there is APC mutation, what will be the result?
So there will be accumulation of beta-catenin.
Beta-catenin will not be associated with APC because APC is not there. Okay, APC is actually tumor suppressor gene. It is not there. So beta-catenin will be free inside the cell. It will cause cell proliferation. And mutation of this gene leads to gastric adenocarcinoma and proximal polyposis syndrome. Okay, so actually why proximal polyposis is added, the reason behind it is this syndrome is associated with multiple fundic gland type polyps in the stomach. Okay, multiple fundic gland polyps along with the stomach cancer. Okay, sit down. Apart from these two syndromes, there are further two more syndromes which are associated with stomach cancer, but these two syndromes are not specific for stomach cancer. because in these two syndromes there could be colon cancer also. Okay, so the other two syndromes are Peutz-Jeghers syndrome and juvenile polyposis syndrome. If you can remember, you can also tell the name of these two syndromes, but these two syndromes are associated with stomach cancer. Okay, clear? Okay. Now coming to the clinical features. So the clinical features of a person or patient having stomach cancer are persistent abdominal pain, which is quite evident. There is a tumor in the stomach. Tumor can undergo necrosis, can cause inflammation, so it can lead to persistent abdominal pain. But persistent abdominal pain is not specific for stomach cancer. Clear? Why it is not specific? তুমি বলো কেন why it is not specific? তুমি বলো. Yes. তোমাকে বলছি. হ্যাঁ, yes. Why this persistent abdominal pain is not specific for stomach cancer? Yes? আচ্ছা মাইকটা কি দাও তো, পাস করো তো। বলো।
Because it radiates in the whole stomach. পুরো স্টমাকেই হচ্ছে, তো কোনো স্পেসিফিক জায়গা নেই।
Radiates in whole stomach তাতে কি হয়েছে? Why it is not specific for stomach cancer? পাশে জনকে দাও। তুমি বলো।
স্যার এগুলো অন্যান্য রিজনের কারণে হতে পারে।
অন্য কারণে হতে পারে। Yes, very good. বসো। Because stomach, it is not specific for stomach cancer. Why? Because persistent abdominal pain could also happen if the person is having peptic ulcer. It could also develop if person is having cholecystitis or pancreatitis. That can also lead to abdominal pain. Okay. The second clinical feature is gastric distension and vomiting. Okay. So again, gastric distension means actually abdominal distension. Okay, abdominal distension it is talking about, and vomiting. This is also not specific because abdominal distension and vomiting can be associated with many other things like indigestion or intestinal obstruction, but it is seen in gastric cancer. The third one is loss of weight. Cachexia, এটা কেউ বলতে পারবে? তুমি কার কাছে মাইক আছে? তোমার কাছে, পাশে জনকে দাও। What is cachexia?
Loss of weight. Cachexia is loss of weight.
Loss of
weight.
মানে একটু রোগা হয়ে যাওয়া, যেটা সাধারণত বলা হয় রোগা হয়ে গেছে, that is called as cachexia. Okay, cachexia could be due to many reasons. One of the reason is any cancer can lead to cachexia, that is called as cancer cachexia. ঠিক আছে, আর কি কারণে হতে পারে ক্যান্সার ছাড়া?
Malnutrition.
Yes, malnutrition. Okay, আর tuberculosis is also there. Tuberculosis, AIDS ওর জন্য হতে পারে। ঠিক আছে, ওকে বসো। The fourth one is loss of appetite. Okay, the gastric cancer patient loses the appetite because if there is swelling present in the stomach, it will reduce the volume of the stomach, so the hunger will decrease. Okay, the fifth one is anemia. Why they develop anemia? Because of this malignancy they bleed. There is intra-abdominal bleeding, and it also causes weakness, malaise, these kind of symptoms. Okay, now spread of stomach cancer. Okay, there is something special, direct spread. মাইকটা কার কাছে আছে? আচ্ছা, পাশে জনকে দাও। What do you understand by direct spread? তুমি কি বুঝতে পারছো এটাতে বলতে পারবে? ওকে, পাশে জনকে দাও। তুমি কি বুঝতে পারছো?
Sir, submucosal to
Yes, মানে একটা stomach cancer arises from the mucosa. It invades submucosa, muscularis propria, then subserosa. Ultimately, it can breach the serosa. Okay, that is called as direct spread. Another one is transcoelomic spread. What is that? What is transcoelomic spread? এটা কি? পাশে জনকে দাও।
So it can spread from the stomach to ovaries, both the
How?
ovaries.
কোথায় আছে স্টমাক, কোথায় আছে ওভারি? How? How this happens? পাশে জনকে দাও। How this happens? কিভাবে হচ্ছে?
লিম্ফেটিক সিস্টেম।
কি?
লিম্ফেটিক সিস্টেমের মাধ্যমে।
জোরে বলো।
লিম্ফ নোডের মাধ্যমে।
লিম্ফ নোড মানে স্টমাক থেকে আগে লিম্ফ নোডে যাচ্ছে, ঠিক আছে? লিম্ফ নোড মানে কোন লিম্ফ নোড? গ্যাস স্টমাকের আশেপাশে যে লিম্ফ নোড গুলো আছে সেখানে যাবে, তারপর তারপর কোথায় যাবে?
ওভারিয়ান পোর্শন।
ইয়েস,
প্যারাইলিয়াক লিম্ফ নোড।
জোরে বলো, মাইকে বলো না।
প্যারাইলিয়াক লিম্ফ নোডে যাচ্ছে দিয়ে তারপর
লিম্ফ নোডে থেকে কিন্তু ওভারিতে যেতে পারবে না। ইট ইজ ভেরি ডিফিকাল্ট। লিম্ফ্যাটিক স্প্রেড পরে আছে। দিস ইজ ট্রান্সসিলোমিক ডিসেমিনেশন অর ট্রান্সসিলোমিক স্প্রেড। ঠিক আছে, এইদিকে মাইকটা পাস করো, এইদিকে এইদিকে পাস করো। তোমরা কেউ বলতে পারবে? এইদিকে পাস করো, তুমি ধরো মাইকটা। Tell me how stomach cancers are reaching from stomach to ovaries. বলতে পারবে কিভাবে? মাইকে বলো, কি বলছো? মাইকটা পাশে নিয়ে এসো, হ্যাঁ বলো।
To the peritoneum.
Yes, through the peritoneum. Once it breaches the serosa, it gets access to the whole of the peritoneum. It can go anywhere in the peritoneum. Okay, তারপর এটা সেরোজা থেকে বেরিয়ে এসে পেরিটোনিয়ামে ছড়িয়ে যাবে। Most commonly it goes to the ovaries and form bilateral ovarian masses. Okay, clear? This is called as Krukenberg tumor. Okay, in the Krukenberg tumor USG তে দেখা যায় যে bilateral ovaries are swollen, ফুলে গেছে, ছবিটা আছে এইরকম। তো ফার্স্ট থিং a doctor thinks about ovarian cancer, but a doctor should think that if the both ovaries are involved, you have to think it could be due to secondary deposit from other cancer like stomach cancer. Okay, because if it is primary, if it is the primary ovarian cancer, it usually involves one side, not the both side. Clear? Are you understanding? So the ovarian means the ovaries are involved in the stomach cancer because of transcoelomic spread. Okay, কিভাবে হয়েছে পাশে জনকে দাও। You tell me about transcoelomic spread.
সেরোসা থেকে
Is breached by the tumor cells.
Yes.
Yes, then
সেরোসা থেকে পেরিটোনিয়ামে আসছে।
very good.
সেখান থেকে
Then it disseminates to the ovaries. This is the pathway of transcoelomic dissemination. Fine. It causes which tumor?
Krukenberg
Tumor. Yes. So Krukenberg tumor is primary or secondary?
Secondary.
Secondary. It is not a primary ovarian tumor. Actually, patient is not having any kind of ovarian tumor. He is having stomach cancer. So you have to treat the stomach cancer. If you go and treat the ovarian cancer, you will not be able to treat the patient. Clear? Why I am stressing here? Because here you have to treat stomach cancer, not the ovarian cancer. Initially you will see that in the initial investigation you will see in the ESG it is showing that ovarian masses, and stomach cancer could be hidden. I have told you there are 4 types. Infiltrated type is most commonly it is hidden. There is no ulcer, no growth, nothing. So the stomach cancer is there, but it is hidden, and the ovaries are swollen up, so it is visible. So a doctor will think that must be some ovarian cancer, but when he will treat for ovarian cancer, patient will not respond. Why he will not respond? Because patient is not having ovarian cancer, he is having stomach cancer. So you have to think in this way. If both ovaries are involved, you should think it could be secondary, means metastasis from some other cancer. Most commonly it comes from stomach, but it can also come from some other tumors also. Okay, clear? Okay, next one is lymphatic spread. Okay, now tumi bolo, what are the lymphatic means lymph nodes present in nearby the stomach?
Left gastric lymph node.
Yes.
Left gastric lymph node.
Okay.
Right gastric lymph node.
Very good. So all the lymph nodes are intra-abdominal or extra-abdominal?
Extra-abdominal.
Yes. Extra.
No, sorry, intra-abdominal.
Intra-abdominal. Okay. Very specific or very abnormal finding is seen in stomach cancer patient, that they have swollen supraclavicular lymph node on the left side, not on the right side. On the left side there is supraclavicular lymph node swelling in the stomach cancer patient, which is very much unexpected. Clear? That is called as Virchow sign or Virchow's lymph node. This is on the left side. On the supraclavicular region there is lymph node. Other lymph nodes are also swollen, but if there is supraclavicular lymph node swelling is there, someone will think that there could be some upper extremity lesion or some problem with the head neck region. There could be some other lesion in the head neck region. But if a patient is showing a single swollen lymph node on the left side of the supraclavicular region, you should also think about stomach cancer. Clear? One thing I didn't mention here, that is called as Sister Mary Joseph nodules. Have you heard about this? These are the lymph nodes present around the umbilicus, and these lymph nodes are because of stomach cancer. Okay? So very abnormal kind of presentation is seen here in stomach cancer, not seen in most of the other cancers. Okay? Clear? Sit down. So this was the lymphatic spread. Yes. So you tell me, what are the abnormal presentations of stomach cancer? If patient is having abdominal pain, that could be explained, that is explainable, maybe due to some stomach related abnormality. What are the abnormal presentations of stomach cancer?
Clinical signs.
Yes.
Vomiting.
Abnormal clinical presentations.
Distended abdomen.
Yes.
Distended abdomen.
Jore bolo.
Sir, distended abdomen.
No, that is the normal, that is expected. Abnormal findings are this one. Virchow's lymph node, Sister Mary Joseph nodules, and Krukenberg's tumor. These are the abnormal presentations. Okay, sit down. So hematogenous spread, it can spread to any organ. Most commonly it spreads to liver, lung, brain and bones. Okay. Now I have already discussed that clinical syndromes. Complications of gastric cancer. One complication is hemorrhage. Hemorrhage can lead to hematemesis or melena. Okay. There is কত মিনিট বাকি আছে 5 মিনিট 3 মিনিট ওকে আমাকে তাড়াতাড়ি শেষ করতে হবে তোমার কার কাছে মাইক আছে আর তুমি বলো what do you mean by hematemesis?
Hematemesis means vomiting of blood.
কি
Vomiting of blood.
Yes, very good. Vomiting of blood. So this could happen in stomach cancer. Okay. What do you mean by melena?
If blood is found in stool,
blood, not blood, it is actually changed form of blood. That is due to bleeding. That is due to intra-abdominal bleeding. But that has been changed. And it has changed to a bit blackish colored stool. Okay. Patient will tell you very black colored stool, and when the water was passed, the water turned reddish. Okay, this is the history given by the patient. Okay, sit down. Other complication is obstruction. It can lead to intestinal obstruction. The third one is perforation. How this perforation can develop? This side. Once the tumor reaches up to the serosa, and suppose the tumor part undergoes necrosis. Necrosis is very common in the tumors, malignant tumors. So it can lead to perforation. Are you getting my point? Okay. And also it can lead to jaundice by involving the bile duct. Okay, thank you.